In this video, we're going to go through when to decide whether or not you should be having surgery for hip impingement and how to make that decision. Now, FAI syndrome, better known as hip impingement, can be a really debilitating and annoying condition to have, especially in that young, active adult population. So trying to understand when to make that decision to have surgery and whether to have it or not can be a really tricky decision to make. And if this is kind of resonating with you, I want to hear from you in the comment section below, because I think what you'll find from these patient groups is there is an abundance in variation in when people have this surgery and when they don't. Now, I've got a particular thought process with this, and considering that I've been a specialist hip physio for way over a decade dealing with these kind of patients, I want to give my insight and my input to just really kind of clarify where when I've got a patient that I'm treating, at what point do I refer them on to having surgery? Because this is a dilemma that many people have, and often I guess many clinicians have this similar same sentiment. Anytime I teach this topic around the world on my course, physios, sports therapists, osteopaths, anyone really always asks, like, when do you refer them on to surgery? And you know, my sentiments are always the same, but there are a few things that we've got to do first before we get to that stage. Now, first and foremost, if someone's got FAI syndrome and it is confirmed, i.e. there's no hip dysplasia, we know the painful source is coming from the labrum, and they've had a diagnostic injection, we know what we're dealing with, the first and fundamental thing is you've got to try and do physio, because this hip would have had characteristics of FAI syndrome way before they even had hip pain, meaning that it had been able to tolerate whatever sport and exercise that hip was being put through at that time. However, now it can't. So it's a case of educating the patient and really understanding how we're going to try and get to that outcome of managing someone conservatively without the need for surgery. Now, if someone's had hip pain for months and months, if not years, that recovery isn't going to be quick. The adaptations aren't going to be quick. You're going to play around with the angles of the hip when using rehab exercises, the type of exercise, the load, the dose, the response, impact, non-impact, dynamic, static. All of these things take time. You cannot do everything at the same time. I always refer back to this kind of rule of, like, what is your outcome from rehab? Are you in a net gain or a net loss? Because if you're in a net gain, you're going to be getting improvements more than where you are at day zero, and those improvements might be subtle. There might be just little improvements where, well, I can sit for a bit longer, or I can walk for a bit longer, and it will take time. But you could also be in a net loss where from the day zero your symptoms have flared up, you're always in a flare up, you're back to the start again, you're plateaued, everything is irritating the hip. At that point you're not making any progress, because you're either the same as day one or you're worse, and that's a net loss. So you want to see some net gain, and if you are seeing a net gain and improvement, you're on the right track. But the difficulty is, like, that can take a bit of time. Now, often in regards to kind of prognosis and how long this recovery will take, patients will always ask me, like, if we're going to do this conservatively, how much time do I have to give it? How long is it going to take to get me back running or playing football or whatever it is? And it takes a little bit of time, and that time often is months. And I would say that realistically, you need to give yourself a good, almost like a 6 to 10 month window to really commit to this rehab. Because if they're in that net gain and it's improving, it may well be that it takes that long to get to that point. Now, there are certain caveats that will hinder some of that response and hinder their ability to get to where they want to get to, whether it is their expectations being too high from an elite sporting perspective. It might be that the kind of sport that they do hinders their ability to get back to that. You know, if you're thinking of a powerlifter or a time trialist or someone that needs very particular full ranges of movement that are often reduced as a result of someone who has FAI syndrome, those are things that sometimes can impact that decision as to when or whether to have surgery, based on the fact that the outcomes can sometimes be a little bit more impaired at that latter stage. But generally, you know, general population may not necessarily fit into that bracket. They might be happy making some adaptations to the way that they exercise, to the way that they train, if it means that their hip is pain-free and they are able to do those things. However, imagine this scenario. You've got your patient, or you are a patient, you're doing your physio, and month by month things are getting better, then you're on the right track. But what about if initially you had an improvement and it plateaus, or you are that patient that is in that net loss? Well, that decision as to whether to have surgery or not starts to be a bit more frank. Should someone be having surgery without having physio? 100% not, because loads of people can manage quite well conservatively with physio. But do we want to be doing physio in someone who is in a net loss or plateaued for 10 months before making that decision? Probably not, because you'll soon know if you're giving someone a 6 to 10 month window to rehab, really by month 2 or 3, if all they're doing is regressing or not progressing at all, that decision is it's probably going to be a bit more apparent in regards to whether or not we refer someone to get that orthopedic input, to understand whether or not surgery is going to be the right decision for them. And that's a really tricky thing, because people are different. You know, some people are a little bit more anxious, a little bit more stressed, maybe catastrophize a little bit more, probably a bit more fear avoidant. On the other end of the spectrum, you've got people who are a bit more stoic, a bit more resilient, that possibly might be a better candidate to do it sooner. And other ones that we know from literature, often the people who have those psychological predictors have a less, or let's say a slight decreased chance of optimal recovery in comparison to those that don't. So that will come into then also influence the decision as to whether or not someone should or shouldn't have invasive intervention. Now, I have to caveat this stuff by saying I'm the real super big advocate for people having hip arthroscopies for FAI syndrome. If, like from the other videos I've posted before, you've got the right person, the right surgeon and the right physio as part of that total package of care to enable someone to get that outcome. But also, if you are going to have it, like, you need to figure out, like, I need to have it at the right time. Now, sometimes, depending on what country you're in, there could be a delay and a wait, especially if you're going like national health system and you're on a kind of a waiting list, that can take a bit of time. But in other instances, if you're paying for it and you've got it and it's a bit more accessible, you have to ask that question, well, like, how much benefit am I going to get? Which essentially is like if you're flogging a dead horse and just going round and round and through the motions of having physio and you're not seeing any improvement, you have to understand, why am I not seeing that improvement? What is it stopping me from getting better? And what can I do to take things further? If by month 3, by month 4, we're at that point, well, that's going to be the point in time where you would say, right, possibly surgery is the option. But even before that point, my first thing that I mentioned at the beginning of this video is really key to consider. You have to understand whether or not that surgery is going to be the right surgery for you. And in order to do that, you have to really 100% be confident that if you've got hip pain and a labral tear, it is definitely from FAI syndrome, because there are so many hips that will have correlating hip dysplasia with FAI syndrome. And that's really, really paramount to consider, because you may well have had an X-ray, you may well have had an MRI, and those two things hand in hand realistically don't refute the possibility of hip dysplasia being present, because on an X-ray it might be missed, on an MRI it might not pick it up. So you could have a diagnostic injection that confirms a labrum is the source of pain, but we don't know if there is any instability or dysplastic component to it. And that's why things like 3D CT imaging and motion analysis are really key tools at understanding whether or not there are other factors contributing to why someone has that labral tear. The last thing you'd want to do is have an instability or a laxity of the capsule or an instability of the joint that hasn't been identified, but you have characteristics of FAI syndrome like a CAM or like a Pincer that have been picked up on imaging that will present like it does, because it's an intra-articular component in the hip that causes pain, similar to FAI, similar to hip dysplasia, that you're then going to have surgery for. Well, arguably that's probably the worst thing you could do if you've got a lax ligament, having surgery to repair something else and potentially making that laxity worse without understanding the full components of what that hip morphology is. So even if you're getting to a point of 3 or 4 months down the line and the rehab isn't working, it's not just a carte blanche, right, everyone go for surgery. It is a case of, well, look, let's take a step back. Let's reevaluate what we think is going on. Let's try and consider the fact that, well, do we know the diagnosis, or are we working with a hypothesis? Because those things are very different. Do we know definitely the thing that hurts? And do we know the thing that's caused that thing to become painful? Those are real simple, basic due diligence tests. And you've got to consider this, right? If I was with you now, you, person watching this, and you're thinking, right, Mehmet, I'm thinking about buying a new phone and I'm looking into phone contracts. The amount of due diligence that you'll do, finding the right tariff, finding the right contract, finding the right shop, discounts from your work, like free text, free internet, free minutes, better phone, more memory. You'll do all of these things naturally. It's no different, and if not, probably even more important for your own health. So if you're going down the route of needing surgery or seeing a surgeon or getting all of these things done, do more than what you would do for figuring out your phone tariff. Make sure the diagnosis is correct. Make sure that you've got everything else nullified. Make sure that you're the right surgical candidate for it. And even at that point, you've still got more checks to do, because you've got to make sure that you find a right surgeon who does a high volume of these, who is specialist in hips, who sees it a lot, and a physio who deals with this post-operatively, that can see you, support you, and get you the outcomes that you need. All of these things are just fundamental basics that you have to do that unfortunately can sometimes get overlooked. It's the most simple things that if you just get these things right, often your outcomes can be so much better. So in answer to kind of some of the points that I've been alluding to over this video, yes, there's a huge possibility you can do well conservatively if things aren't getting any better. And this is why I wanted you guys to kind of integrate and comment below, because some of you may not have waited as long to have had surgery and have done excellently, and others might have waited 2 years to have had surgery and done excellently, and others the contrast to that. So it's important not necessarily to compare yourselves to everyone, because everyone is different. And also, just because someone has had a better or worse outcome doesn't necessarily contribute to how you're going to do. Make sure that you do all your checks, cross all the T's, dot all the I's, do your checks, make sure that you're optimizing everything at every stage possible. By doing that, you're optimizing your outcomes. The only other thing that we need to probably be cautious of is, in some situations, that window of opportunity to have surgery may well have diminished. You may have progressed through that continuum of hip health from a FAI, hip dysplasia type hip, into an arthritic precursor hip, some condylar defects, bone edema, slight reduction in joint space, and in those instances, often surgery isn't suggested, and actually you're too bad for one and too good for the other, and that's a bit of a grey zone that patients can get stuck in. So it's important to consider, with the rehab, there's also that window of opportunity to consider as to when someone may or may not be a candidate to have surgery. But nonetheless, hopefully that answers the questions. I've got loads more of these videos. Let me know if you like it. Comment, do all of that jargon, subscribe and whatever. Send me a pen pal letter in the post, I don't mind. Watch the videos, let me know what you think.